Hi, everyone. Thank you for joining us today. Today, we will be discussing how cancer being impacted by the pandemic. My name is Katrina, and I'm the Program Manager for Survivorship and Navigation at Georgia Core, which is the Georgia Center for Oncology Research and Education. Today, we have presenters Claire Thevenot and Dr. John McBroom. Claire Thevenot is a patient advocate and the owner of Clarity Patient Advocates in Atlanta, Georgia. She's an oncology certified nurse with several years of experience in working with cancer patients. Claire is also a breast cancer survivor who combines her professional and personal experience in helping patients navigate the overwhelming and confusing healthcare landscape. Dr. John McBroom is a physician and a board-certified gynecologic oncologist at Piedmont Physicians Gynecologic Oncology. He is a certified member of MD Anderson Cancer Network and a fellow of the American College of Surgeons, American Society of Clinical Oncology, and the Society of Gynecologic Oncology. He has published in multiple peer-reviewed journals, presented at national meetings, and has been selected as a Castle Connolly Top Doctor every year since 2013. Thank you both for joining us today.
Thank you, Katrina.
You're welcome. If you have any questions during the presentation, please leave them in the Q&A section, which is to the right of the platform. These questions will be answered during and after the presentation. The webinar will also be available for viewing in a few days. I will now turn the presentation over to Claire and Dr. McBroom.
Thank you, Katrina. We were asking participants if you would type in the chat notes. We were just wondering how, as a patient, you have been impacted by the COVID-19 pandemic, and if you're a healthcare provider, how your patients are being impacted. And just type those in the chat notes and you can see your answers. So our agenda today, we're going to discuss the risk of COVID-19 for cancer patients, recommendations for those at risk, any changes in practice and therapies, insurance in the event of a job loss, advanced care planning, and then we'll have time for questions. And I have a link to some additional resources that you'll be able to find at the Georgia Core website after we're done. I'll show you how to get to that. Okay, individuals with cancer are considered at high risk in general when it comes to COVID-19, and that risk is both in contracting the virus, but also in having more complications with the virus. The risk depends on several factors. First is the type of cancer. Some cancers, such as leukemia and lymphoma that affect the bone marrow, cause a suppression in the immune system, making a patient more susceptible to infection, including the novel coronavirus. We also know from a recent study that I'll discuss in a little bit that patients with metastatic cancer tend to do poor. And another consideration is the treatment regimen a patient is on. Some therapies are more immunosuppressive than others, again, putting a patient at greater risk for infection. In addition, cancer patients in general have more frequent contact with the healthcare system and other patients, meaning that they can be at greater risk of coming into contact with the virus as well. And finally, it's known that certain comorbidities are associated with more severe illness in people who contract COVID-19. Those comorbidities include diabetes, obesity, heart disease, chronic lung conditions, and several others. What is important is that you understand your risk and be very diligent in taking precautions as recommended. And it should be noted that those with a history of cancer who are not in active treatment may also be at higher risk of severe illness from COVID-19. A couple of weeks ago, as I was doing research for this presentation, there was information on the cancer.gov site suggesting that a history of cancer was not a risk factor. However, just a few days ago, a new study was published indicating that those with a cancer history do have a higher risk of illness and complications. And I went back to the cancer.gov site and I saw that it had been updated. And that just goes to show how quickly things are changing as we're learning more about the virus. Complications that can occur with COVID-19 include pneumonia and severe symptomology. admission to the ICU, mechanical ventilation, and death. There were 2 recent studies that I pulled on patients with cancer who have contracted COVID-19. There was a study from Wuhan conducted in January and February that was released just at the end of last week, at the end of April. And it looked at 105 patients that were COVID, that had cancer that were COVID positive. And they compared those to patients with similarly aged patients with COVID, and there were 536 of those that they compared them with. And all of these patients in Wuhan were in 14 different hospitals. There's also a study published on May 1st that looked at 218 COVID positive cancer patients hospitalized in the Bronx, New York, from the middle of March to the beginning of April. And what these studies confirmed is that cancer patients across the board are at higher risk of infection of COVID-19 and are more likely to have severe complications, which I discussed, and those include the critical symptoms, ICU admission, mechanical ventilation, and death. And the cancer patients most likely to have more severe outcomes include those with hematological or lung cancer, those who have stage 4 disease, mostly with lung metastasis, those who had surgery or immunotherapy within 40 days of the onset of symptoms, and those with certain comorbidities. And I didn't include the numbers of illness and death in this presentation. And the reason is that those numbers are pretty dramatic and can't really be applied to any individual case. The patients in these studies were already hospitalized and were very sick to begin with. And many of the ones in Wuhan were actually infected while they were hospitalized. In the New York study, all those patients came, most of those patients, not all of them, but most of them came from nursing homes and were already considered pretty frail. And in addition, we are learning about COVID every day and what the situation changed. So it's hard to extrapolate one study into the whole population. But the overall takeaway here is that patients with cancer are at higher risk in general for both contracting the virus and for more serious complications. So the goal for cancer patients really should be to prevent infection to start with. In addition to the risk of infection, the coronavirus poses other concerns for cancer patients as well. There is the stress of the fear of contracting the virus and the possible complications, as well as anxiety over delays of diagnosis and or treatment. In a survey conducted by the American Cancer Society Cancer Action Network, they surveyed 1,219 people, and almost a quarter of those respondents reported that they had a delay in their treatment, and almost half of those, they didn't even know when their treatment was going to be rescheduled. So you know that's going to be very stressful for patients. In addition, many people are experiencing a job loss and diminished economic security during the pandemic. Complicating that often is that there's a loss of the employee-sponsored health plan as well. In the same survey I just mentioned, 385 of respondents reported that COVID-19 had, quote, had a notable impact on their financial situation that affects their ability to pay for health care. And this highlights the increased stress that the pandemic can cause in people who are already burdened with cancer. Dr. McBroom, can you tell us some of what your patients have been experiencing regarding increased stress or other concerns related to the pandemic?
Oh, sure. Thank you. Hopefully you can hear me. I would concur with what you said in terms of the impact on the patients in regards to fear. I think that you won't see it as much now as you will later, but I do think there's very likely going to be more delay in diagnosis as people don't pay attention to early warning signs of cancer. So they're going to come late, particularly if the signs would bring them to the emergency room. So people are afraid to go to the emergency room. You know, their primary doctor's offices are closed or cut back. So I think that you're going to see and a delayed effect on that, and that will hope you'll see more cancers that we usually catch earlier diagnosed later. Have a colleague who is doing a procedure on a patient who self-treated, thought she had hemorrhoids, but in fact ended up having anal cancer, and had self-treated for a while because of concerns about the COVID virus. And that's one example. I think the financial impacts also a good point to bring up. As people lose their jobs and they have lack of insurance, they're less likely to engage the system when they have early signs. I think, things outside of our cancer arena, things like coronary artery disease or, appendicitis, I think you're going to see people coming in with later diagnosis of appendicitis, and something that's simple and laparoscopic is going to end up being more complicated, open, and has a bigger burden on the system.
That's a good point. Okay, so what are the recommendations for cancer patients who are at increased risk for the virus? Well, the answer is the same for those at average risk. It's social distancing that should be maintained. Frequent hand washing is a key, as well as being cautious not to touch your face. The CDC has recommended that everyone wear a mask if it's necessary to leave the home. And it's recommended that people clean and disinfect high-touch areas around their home often. Lastly, it's important to avoid anyone who is sick or has been exposed to the coronavirus. And if you are diligent in following these guidelines, again, we do that with the hope that we will prevent infection. So with regards to cancer screening, the American Society of Clinical Oncology, ASCO, recommends delayed routine screening until the pandemic is under control. And routine screening would be, for example, a regularly scheduled mammography or colonoscopy. And as if there's a suspicion of cancer, then the scheduling of diagnostic tests would be on the advice of your physician. And this kind of goes back to what you were saying, Dr. McBroom, that some people might not seek screening tests just out of fear of being exposed. So if you suspect you may have COVID-19 or have been exposed, it's recommended you do not go directly to the hospital or clinic. If it's an emergency, you should call 911 and let them know of a possible COVID case. Otherwise, if you're in active treatment, you should call your oncologist and let him or her advise you what to do. If you are not in active treatment, you should instead call your primary care physician for instructions. Regarding tested for COVID-19, as you know, testing is a tricky endeavor. The CDC has listed people with underlying conditions as priority 2 behind healthcare workers and those who are already hospitalized. While that is what is recommended, in reality, however, testing is at the discretion of the clinician and is subject to availability. The prevalence of COVID in some areas may affect the testing. If higher rates of COVID are considered in certain areas, they may be more aggressive with testing if that testing is available. Now let's discuss changes you may see at your local clinic or doctor's office. Many practices are turning to telehealth visits via telephone or video during this time. And the telehealth visit is good for those visits where you're not getting treatment and are just with a clinician for symptom management or follow-up. Many clinics are limiting visitors that may accompany a patient. They may limit it to 1 or 2 people who may be with the patient, or they may not allow visitors at all. And while this may be disappointing for some, it reduces the overall number of people that staff and patients are exposed to, and it also allows more room for social distancing. Many clinics are also pre-screening patients before a visit. In those cases, they may call the patient the night before to make sure they're symptom-free. And again, they're usually assessing them upon entrance to the clinic for a fever or any other symptoms. Finally, many clinics are requiring staff, patients, and clinic spaces, they're requiring staff and patients and guests to wear masks. And clinic spaces are being arranged to allow for more space between patients so that they can allow for social distancing. Dr. McBroom, what are some of the changes that you have implemented in your practice and that you're doing?
Sure, thank you. I'll talk a little bit about the hospital system. I think in Atlanta, all the hospitals are not allowing visitors except for very limited circumstances. I think for Piedmont, active dying is one, and same day surgery where they're going home the same day. But there's strict limitations to that as well. So definitely seeing limited visitors in the hospital. Also for patients who are designated as they've sequestered all the COVID positive and rule out COVID patients into one area of the hospital. Now the new tower opening up, they're in another building. I think there's some other areas in the country where they're doing that, where they're having kind of one hospital as the COVID positive hospital and the others not. That's harder to do when they're different systems. The mask requirements changed with the hospital. Initially, I believe there was a kind of a more of a liberal policy, and they were concerned about overutilizing masks and not having them available. So you weren't really allowed to wear masks unless you were actively taking care of a patient who was there's concerns of COVID. And now that's changed, obviously, and everybody wears a mask in the hospital. Other things that are happening, there's limitations to the entryways in terms of the places that people can get into the hospital, and at each of the entryways, there's a screening process where you're asked questions about, do you have a fever, et cetera. And then there's a temperature check. So in terms of our office and things that have done, we do the same thing in terms of not allowing visitors, in that there's a pre-screen call appointment to ask patients if they have symptoms. When they come in, they're checked and screened. Mask, we have people wear masks, and if they don't have a mask, we make one available to them. And then we certainly limit our visits. With Gynecology, trying to do exams by telehealth is probably a little more challenging than some other specialties. But for new patients with a suspected cancer diagnosis, those appointments are still happening. For surveillance, for not active treatment, those patients have been pushed off. We'd probably look at every 6 or 12 months along the ASCO recommendations. For people who are getting chemotherapy, we're seeing them in the infusion center instead of having to come to the office and then over to the infusion center. So those are some of the changes that we're making in the office. And we certainly use telehealth a lot more, particularly for follow-up appointments.
How is the telehealth working for you? I know some people aren't technically as gifted as others.
I'm in the non-gifted group. So unfortunately, I have a PA that is. So with her help, we've been able to do that. And it's still it's discombobulated trying to get somebody to be on at 10:15 if that's the time of their appointment. Quite frankly, I think a lot of my appointments that those are phone calls because most of the time it's discussing results or recent surgery and talking about their pathology or their labs or imaging, because the surveillance patients have been pushed off and the new patients we're actually seeing. And then if a patient needs an exam because they have a particular problem, we're not really able to triage that through telehealth. We actually have to see them. So
right. Okay, so here is a picture. This is a clinic in Texas in early April. A woman posted this on her Facebook page. Since she was not allowed to have anyone with her during her chemotherapy treatment, her husband showed up and with a sign outside the window. And I threw this in here because I just thought it was a lovely example of a tender gesture at a difficult time. So there are also some adjustments in therapy that may be considered to help reduce the opportunity for virus transmission. One option is changing the dosing schedules of treatment so that the patient has fewer in-person visits. If available, a physician might switch to oral medication that provides a similar benefit. Radiation oncologists may elect short course or hypofractionated radiation. For those that are in surveillance or due for labs or scans, the time between those may be extended. Another change we're seeing is decreased opportunities for participation in clinical trials during the pandemic. One study by the publication Biopharma Dive indicated that over 70 institutions had reported a delay in at least one clinical trial. The ones that were delayed, the ones that were delayed were the ones that weren't in active status yet. They were the ones that were being planned, and the ones that were still accruing patients. And finally, it's some therapies may be arranged to be provided at home. As an example, a University of Pennsylvania in Philadelphia pilot program was started in the fall of 2019, and that provided for 2 chemotherapy regimens to be administered at home. One of those was an injection and the other was infusion. And they accrued about 40 patients participation in the first 6 months of that program, but as the pandemic hit, the program grew by 300%. So in the 4 weeks starting March 10th, the therapies that they started delivering at home increased from 2 to 7, and the number of patients referred grew by 135. And so there is some controversy surrounding delivering therapies at home and obviously some safety concerns, but I'm thinking that there are going to be more home administrations of cancer therapies over the next few years. In 2019, the National Comprehensive Cancer Network, NCCN, presented a toolkit with guidance on shifting some inpatient therapies to the outpatient setting and eventually home. And with the onset of COVID-19, NCCN updated the guidelines for member hospitals to utilize. Dr. McBroom, what are some of the changes that you're seeing in therapies with your patients? And can you discuss clinical trials too? I know we talked about this earlier in the week.
Sure. In my practice, at least for the chemotherapy part, people who are in active treatment, we've pretty much kept everybody on active treatment. We really haven't changed that. I think that in terms of starting therapy, at least for what we deal with, there's some opportunities to change things. For instance, patients with ovarian cancer have an option to start with chemotherapy versus start with surgery. And so I think neoadjuvant chemotherapy. So I think we probably are doing neoadjuvant chemotherapy more often than we usually do, as chemotherapy is an outpatient procedure, whereas doing their surgery or the debulking up front with a higher risk for being in the ICU. We're trying to keep people out of the ICU. So I think that's been a change for us. People on active treatment, we really haven't switched anybody from something that's working to an oral agent. I have been on a few group discussions with gynecologists in other areas of the country where there's a conversation about switching people from chemotherapy to a group of oral medications called PARP inhibitors. I haven't done that. That would be thinking outside the box, but there were people in the group discussion that were either considering that or doing that. In areas probably that are harder hit, like New York area, I would imagine. In terms of clinical trials, I'm pretty limited in the trials that I offer, so I usually am fairly aggressive in getting people out to clinical trials if we don't have something acceptable locally. And we've had 3 patients that we have tried to send to Minnesota for a vaccine trial, and they were essentially Mayo Clinic. They were closed to accruing new patients while the COVID crisis is going on. So those patients had to get like 3rd-line chemotherapy instead of being put on trial. And I think that's to their detriment. I would have preferred to have them on on a clinical trial. So that's definitely impacted not our clinical trials, but our ability to get people on clinical trials at other locations.
Yeah, that has to be disappointing, I'm sure.
Sure, it's extremely disappointing for, you know, us and the patient.
Sure. Sorry, I'm not good at the technology either here. So in light of the current situation, some organizations such as the American Society of Hematology and American College of Surgeons have published treatment guidelines, and as they become available, ASCO is publishing them on their website, and the link is included there. And the guidelines may be useful in helping patients and their physicians in making some treatment decisions. It must be said that any changes in therapy are to be decided on a case-by-case situation between the patient and his or her physician. The key considerations, of course, are weighing the risk of making changes in surveillance and treatment versus the risk of being exposed to the virus. A patient that has more aggressive disease may find that the risk of changing treatments outweighs the risk of being exposed to COVID-19. Another person who's on who has more controlled disease may be able to delay things a little bit more. And I'm going to shift gears and talk a little bit about insurance. There have been many reports of people who have found themselves unemployed and thus without insurance due to the coronavirus. And I want to mention some options. And since there's some time constraints in making changes, it's important to start looking into options right away after the loss of insurance. Options available may be Cobra plans, plans of a spouse or parent, in the case of a young adult, Medicaid, and the marketplace, and I'll give a little highlight of each one. Cobra allows you to stay on your employer's plan, but you must pay all of the premiums. The option is only available if the employer is still carrying the insurance. If the employer is going out of business or canceling this healthcare benefit, it won't be an option. Cobra offers continuity, which is nice for patients, but because the individual covers the full cost of the premiums, it can be pretty expensive. If you've incurred some large expenses already this year, however, and have met the deductible and maximum out of pocket for the year, you may find that this option will cost less in the short term than some of the other options. In other words, if you switch plans and have a lower premium, but you still expect significant treatment costs, you may end up paying more once you factor in needing another deductible and all of the co-insurance. And this is why it's important to weigh all of the options. The second option for some people may be a spouse's plan, or some young adults may be able to be on their parents' plan. Adult children can be on a parent's plan until they turn 26. These can also be expensive, but they're usually less expensive than Cobra. And while it may be outside of the enrollment period, which is typically towards the end of the year, a loss of insurance would be considered a qualifying event. In very limited circumstances, Medicaid may be an option. Georgia does not have a Medicaid expansion program, so the income limits are very low, meaning a lot of people won't qualify, but in other states they're a little broader. Families where there has been a sudden loss of income may find that they do qualify because it's income-based. You can go to healthcare.gov and put in an application, and if you don't qualify, they will let you know if you qualify for tax credits for an exchange plan. And finally, there is the marketplace. These are the plans that became available with the Affordable Care Act, also known as Obamacare. While enrollment is closed and has not been reopened due to the pandemic, a loss of insurance is a qualifying event. You only have 60 days from that qualifying event, however, so you have a limited amount of time to look at your options and weigh what might be best in your situation. What's nice about the exchange programs is that the exchange plans is that they have different coverage levels called tiers, and they also have a way to evaluate them on the website, so that makes it a little bit easier. There are also premium subsidies and tax credits that may be available based on ability to pay. And you can get more information about those plans at healthcare.gov. And the last thing I wanted to discuss is advanced care planning. I believe that everyone, no matter your age or health status, should have advanced directives. Those directives include a living will and a healthcare power of attorney, and they let your family and physicians know what you would want in the way of end-of-life care. For example, would you want to be intubated? Would you want to be given IV food and nutrition? The living will spells out your treatment wishes, and the healthcare power of attorney designates someone to make healthcare decisions for you if you are unable to do that for yourself. And while I believe these documents are always important, the current pandemic makes it more so, and I've read a lot that there's been more interest surrounding the completion of these documents in the last few weeks. There's also a POST, which is a physician order for life-sustaining treatment, and it's often recommended for those with a serious health condition. And those are medical orders signed by a physician that indicate what treatments were to be given in an emergency. And because they're physician orders, they must be followed by EMT and hospital staff. And I've listed here several organizations that can help with making these choices. The first one is 5 Wishes. I highly recommend 5 Wishes. They have a simple document that meets most state requirements, including Georgia's. And during the crisis, they've made the document free for download. So if you don't already have your advanced directives, I include you to do this. And you can get your POST through a physician. They would write those orders for you. The other organizations include the Pulse.org, the Conversation Project, and the National Hospice and Palliative Care Organization.org. And these are the resources that I've mentioned during the course of the presentation, and they are available to you at www.georgiacancer.info.org/webinar. So if you want to look further into any of these and other resources, that list will be available to you there. And that concludes my part of the presentation. I wanted to open it up to any questions or comments you may have. You can type it in the questions section of the GoToWebinar. Okay, here's a question. It says, I'm in remission with CML and still taking daily medications for that. I've isolated, but have definitely been concerned if my risk is greater because of the medication I am taking, which is Bolsulit. Dr. McBroom, would you feel comfortable answering that?
Yeah, not my particular area of expertise, so I would just say that with a caveat. But I think in general, if your lab tests are suggesting that your immune system's intact, and that you have normal labs, then I would think that you're not under any greater risk than anyone else, presuming that you don't have any other underlying conditions. Nobody really knows. They're still learning about the coronavirus. I don't think there's a consensus yet on whether you can get reinfected with it or not. But I think just as a general rule with any virus, if you're immunocompromised, you're more likely to be susceptible to severe complications from, viral infections or any other infection. I don't know if that's helpful or not, but that's what I would say.
And I would encourage anybody with specific questions to talk to their own physician and see what they recommend. Because as we mentioned earlier, it's really on a case-by-case basis. Do we have any other questions?
I'll share sort of an experience with the coronavirus. and just to kind of show you how things are changing quickly. So well, I think with our hospital initially there was recommendation that you not wear the mask, and so and in fact I think it was put out that if you're wearing a mask you might lose your employment, because we really wanted to have those masks available for when they needed them. And so we had a patient who came in for a non-cancer reason, and we were consulted when they found a mask. The patient had a fever, infectious disease, was consulted. We didn't have the fast test at the time. This was over a month ago, and so the patient was evaluated and deemed that she did not have the virus, and so she had a mass and needed surgery. We did surgery, and then she developed a fever after surgery, and we consulted infectious disease at the time for a second time, and again the patient was deemed clinically not to have the virus, and so we went. The test became available, I think, the day after that. Our service went ahead and ordered the test because the rapid test became available, the 6-hour test at the time. And so the patient, several days later, that test came back positive. And so, the patient kind of gone through the system, through the ER, through the OR, the pre-op and the post-op area. One of the pre-op nurses and one of the post-op nurses then subsequently came back positive for the virus. Now, whether it was because of taking care of that patient or because they had, prior exposure, I don't know, and they're doing fine. And then the policy that was in effect for, having been exposed to the patient without protective gear was to not to stay at home, but just to wear a mask, because the mask all of a sudden became okay to wear, and then to just monitor your temperature and monitor symptoms. And I kind of self-isolated for 2 weeks and then re-engaged. But that just kind of shows you, at least within within a larger healthcare system, as new information comes available, there's a change in the policy, and the policy changes very quickly, and everything's really not known about the virus. So I think the best you can do is to be cautious and prudent and careful, and limit needless exposure.
Yeah, as I was preparing some of the slides for this presentation, there was literally a new research trial being published every day. You can barely keep up with it, but it's changing rapidly, and then it's hard to know then what you should do, what should be best practice from one day to the next. Do we have any more questions? I don't see any more questions, Katrina. I think we're good.
Yep, I don't see any more. All right, well, thank you, everyone. Thank you both for that very important information. Of course, if you have any questions after this, just feel free to reach out and we can get you answers to those. I do have a few, and also their contact information is here. These slides will be available with the webinar recording and also separate from it if you just want to review the presentation. The Georgia Core website is georgiacancerinfo.org, and if you need to reach out to us, it's info@georgiacore.org. I do have a couple of announcements. One, Georgia Core is offering a meditation on Thursdays, and it'll be going on for the next 3 Thursdays, and it's taking place on Facebook Live. It's the Georgia Cancer Info Facebook page, and I'll include the link here in the chat. It'll be at 9 a.m. and it's only about 20 to 30 minutes, but it's a great time to refresh and reset your mind for the week and all of the stress that we have been experiencing from the pandemic. I will also be sending an evaluation immediately after the webinar. We would really love your feedback so that we know how to improve and what you really enjoyed about the webinar. And lastly, the resources of this webinar are available at www.georgiacancerinfo.org/cwebinar, and that information will be sent to you as well. I hope that everyone has a great day, and thank you for joining us.
Thank you.
Thank you.